Okay, you're going to have heard a lot of this before, and it's very repetitive, but I guess the whole long-acting reversible contraceptive stuff, it just has such a great potential to prevent unwanted pregnancies, really because these contraceptives are now what we call tier 1. So i.e. the most effective contraception we've got, less than 1 pregnancy per 100 women per year, the implants along with your IUD and your IUS, and up there, of course, permanent methods like vasectomy and female sterilization. So you can see that dropping down to second-tier contraception is depot pills, patches, etc., where your pregnancy rates are actually higher. And that's really because, of course, of the use continuation of long-acting reversibles. So really, these are the options for women who really feel they don't want a pregnancy in the next year or two. One of the things that some women say is, oh, I don't want something that's 10 years, Helen. I don't want one of your new copper T380As. You know, I want to get pregnant before that. Well, they need to know, of course, that 6 months later, if they want it taken out of a baby, that's fine. But if it can stay for 10 years, it doesn't have to, of course. And the reason we're getting lots of research in New Zealand over the last few years to show us that if a woman has a termination of pregnancy, for example, and has a IUD put in, this study that we did at Epsom Day Unit a few years ago shows that that woman is 70% less likely to return for a repeat abortion in the next few years than if she left with a pill. And Sally, and that's why we started to teach our Epsom Day Unit nurses to put JDELs in, because our operating surgeons were doing the IUDs. The operating surgeons didn't have time to put the implants in, and so we've taught our nurses to put implants in. So we're offering a whole range of the range of long-acting reversible contraceptives. And we've now put in about 4,000 JDELs in the last few years since we started training in about 2011. I'm going to talk very briefly about the training because I know quite a few GPs are being trained. The training for our nurses actually is some background reading, watching the insertion CD, practicing on the arms, watching me put 2 or 3 in, being watched put 3 or 4 in until we think they're competent, ringing the first 20 women that after training that they do that for so that they absolutely know that they're getting subdermal placement, i.e. that the woman can feel the implants, and they do an MCQ exam. And there's a 6-monthly meeting to discuss any deep insertions, and I'm going to show you some of those in a minute or two, and yearly recertification. So that's what we make our nurses and midwives at ADHB do for JDEL training. I'm obviously going to talk about JDEL here just for a minute or two. I think that if you're going to learn to put JDEL in, and I know that at morning tea there'll be some arm training, you should really be seriously thinking of learning to take them out. Because family planning are getting most of those. Some GPs are having difficulties with removal, and I think it's like everything else. If you're not putting in 1 or 2 JDELs a month, if your practice isn't doing that, it's probably best to have one person who's actually doing that amount. It's like everything else. If you're not doing it often, you kind of forget exactly what you're doing. And if you're not removing often, again, you kind of forget how to do it. And the biggest thing is getting the subdermal placement just right underneath the skin. So it's very important. I mean, you'll probably see that the company don't suggest putting a little bit of local and a little nick in the skin before putting the trocar in, because the trocar is pretty sharp. The trouble is with the trocar, if you're pushing it, trying to get it subdermal, it's very easy to go into the muscle layer, and I'll show you just where the muscle layer is. So it's much better to make a little incision, and then you can tent beautifully with your trocar. We are now, as you can see, we are not putting, or at the beginning we used to be talking about putting the JDEL in the sulcus between the muscles. Why would you ever have done that? You've got everything there to go into. There actually has been JDELs found in the lungs, having gone up through a vessel. So that's very easy if you're putting your JDEL in that sulcus to get into all of this stuff. We are putting it over the body of the deltoid now, far away from any vessels. I've just done a presentation at the Family Planning Clinic of an audit of all our 4,000 insertions for EDU nurses and midwives at ADHB. And I just want to show you that Here were 2 insertions by EDU nurses. They went to family planning or they went to my clinic at Green Lane. Here at family planning, this one rod was palpable and it was taken out. They couldn't feel the other rod. And they were sent to the interventional radiologist. So all of you, ADHB interventional radiologists will not take JDELs out. The ADHB are not prepared for that to happen. You can apply for ACC funding. All GPs can do that. So if you get somebody who's a JDEL, they want it removed. If you can't feel both rods easily, you refer to ACC. They'll fund the $600. You refer them to Nick Dodds, who is at Auckland Radiology in Remuera Road, and he will take them out under ultrasound guidance. So GPs can do that. There's no point in referring them to ADHB because they won't do them there. And, well, then I can do the ACC, but they wait a long time to get to my clinic. So far ahead and do it yourselves, feel free. Just to talk about this one, you can see that this second rod went to the interventional radiologist. In fact, it wasn't in the muscle, but there was quite a bit of subcutaneous fat, and it couldn't be felt very well when it was at family planning. But it was only 5 millimeters deep to the skin and the subcutaneous fat. Here's another that came to my clinic. These rods were removed by the interventional radiologist. They were only 6 millimeters deep to the skin, but they were under the muscle fascia. You have not got a lot of space there. You really need to make sure you are doing subdermal. Here's a wee picture. Nick sent me these pictures with no green stuff on them, and I looked at them and I thought, oh, I don't know what that is. And then he put the green stuff on, so it's much easier to see what you're looking at. Here's this nice little rod. It's sitting subdermally. Here's the muscle fascia. It's subdermal. It's not in the muscle. It's above the muscle fascia. Yay, this one looks lovely. Here's one that is obviously deep. So here we have the fascia over the muscle, along here. Here we have one end of the rod. And here's the rod, and here's the other end of the rod. So it's gone in, but it's just gone under the muscle fascia, and the top now is a little bit deeper. And you can see that here it's 0.9 of a centimeter the length here, and here it's just underneath the muscle fascia here. So it's particularly important if you have somebody who's very, very skinny that you really are making sure it's just subdermal, because the muscle fascia isn't very far away. People talk about implants migrating. Implants, if they're properly put in subdermally, do not migrate. Once they get under the muscle fascia, under the muscle sheath, yes, you can feel them there nicely after you've put it in, but once she starts using her muscle, then they'll migrate up and down into the muscle. So right place, no migration, into the muscle, yes, they can migrate. And just really a bit of a discussion point, as we said, if you're taught to take them out, but you can't feel both easily, probably best to refer to the interventional radiologist. Though if you think you're very skilled at removal, you can talk to the woman, go ahead and take one out, because occasionally the second one's just sitting underneath it, and you can get the second one out. And just moving on to some more of the research that I started to talk about, this is Sally Rose's nice research, again showing like the IUD, if you put an implant in post-abortion in the next 4 years, there was a 74% reduction in subsequent abortion at 4 years compared to those women who were sent away with a pill or Depo-Provera. So, I mean, I think we've got the message, long-acting reversibles are really useful for women. We know all of this. We know the UK medical eligibility criteria. It's exactly the same as the WHO medical eligibility criteria. So if something's a 1, you can use it, and if something's a 4, you can't use it. You've seen these tables before. And I just want to say that we are really, really, really pushing immediate postpartum contraception. And I'll show you why in a few slides in a minute or two. We do very badly for a woman postpartum. They're often sent home to go and see their GPs. They have a young baby. They don't get back to their GPs. They have the number of unintended pregnancies we see EDU for somebody who's had a baby 3 or 6 months ago is large. And it's a real pity. You can see from their criteria that we actually can put an IUD in immediately postpartum. So we're trying to get our obstetricians and gynecologists, and maybe our midwives, to actually think of immediate postpartum IUD insertion after delivery. And that's done internationally, worldwide. There's a Cochrane review, but for some reason New Zealand has really very infrequently offered that. You can actually see that you can give Depo-Provera, you can put an implant in post-delivery, you can give progesterone-only pill, and these do not affect breastfeeding. And hopefully I have the big meta-analysis to show you that result. So this was a big meta-analysis that was done by the World Health Organization, because obviously they realized that it was very important in all parts of the world that women could be offered hormonal contraception, not the pill immediately postpartum if you're breastfeeding. We know it might affect milk supply, but all progesterone-only methods can be offered immediately postpartum. So this review very clearly gave all the randomized evidence, all the observational evidence. It is absolutely fine. And that's why we now have our midwives offering women implant insertion the day after delivery before they go home. This review's just been updated last year, same findings. So really the messages from the research is that the 6-week check is far too late for some women. This study was done in teenagers, so not just teenagers. 50% of menstruations after delivery are preceded by ovulation. We're waiting too long to be thinking of offering contraception. And I think this is kind of sobering. This is a great study that Jane McDonald did. It was published in the International Journal of Contraception last year. Here were women from 4 different health boards in New Zealand. These are women with severe acute maternal morbidity, i.e. women who should really have been offered really good contraception when they had that baby. 94 cases, 86% left hospital without a contraception prescription. And really, Jane, I think this was a very polite comment. In summary, these results indicate substandard care. Now, none of us think that we deliberately are withholding contraception from these women, but we seem not to have the systems in place to organize that will happen. All DHBs, I've just been doing a trip around the country for RAND's call, talking about immediate postpartum contraception, and all DHBs do things very, very differently. ADHB actually talks about contraception at 28 weeks, that's documented, and of course I think that's a really good thing to do. All the way through the pregnancy, there should be a discussion of what you would like to happen after delivery, so that the woman can make some decisions during the process. We really, really, really need those systems in place. And I guess for me, one of the great things about teaching midwives to put JDELs in immediately postpartum is that if that woman, for example, is using an enzyme inducer, and the midwives are taught that JDELs won't be an effective contraceptive method, they're now thinking, oh yes, but I know I can give Depo-Provera because it'll give good contraception even if she's using an enzyme inducer. So there's a much more proactive approach beginning to happen. And we all know that if women actually understand the side effects of contraception, that increases continuation rates. The important thing is that you're telling the truth. We need to have evidence-based side effects. So what you'll find in the package inserts, and at some stage legally we hope we could get those package inserts from the oral contraceptive pill removed, because they do not talk about evidence-based information about side effect profile. What you're getting there is women in studies have been given the pill, for example. Let's talk about the pill. They're asked for the next 6 months to report anything that happens to them. That becomes the pill side effects. Now, we all know that's a nonsense. You have to have compared it with placebo. And we do have placebo-controlled studies. For example, no, I don't have it. We do have placebo-controlled studies. Cochrane has done lots of those. For example, women who have acne, you'll have to have a placebo-controlled study with the pill and placebo to see that it's helping acne. And then you can see that the side effect profile is extremely similar. Nausea, headaches, weight gain. There is no difference between the pill and placebo. So it's very important that we don't suggest to women, you know, here's the pill, look, it might put on a wee bit of weight and your mood might be a little bit, but you just keep going. These are not true. And that suggestion makes a woman think if her mood is decreased, if she's putting on weight, it's due to the pill. She stops the pill, she has an unintended pregnancy. So it's now thought completely unethical to tell women about non-evidence-based side effects. So let's just go to the injectables and see what we can tell women. And this comes from the Faculty of Sexual and Reproductive Health Care, and I'll show you how to get onto this website because it's really kind of useful. I use it all the time. No causal association with injectables between mood change, libido, or headache. Implants, the main evidence-based side effect to tell women about is their irregular bleeding pattern. So we're clear, 1 in 7 women will have their implant removed because they have bleeding in between their periods. The New Zealand data from family planning is extremely similar to that. I think it was 1 in 10. The thing is that you need to tell women, if they're having an implant, if you're one of these women who get their irregular bleeding, don't put up with it. Come back and see me, because if you put a combined pill on top, that will actually help the bleeding. And in family planning, we have young women who are using J-Del for contraception and using the pill continuously, obviously not taking the placebo tablets, but the continuous hormones on top all the time to help their bleeding. And that's perfectly acceptable to do. They've got great contraception. Now their bleeding pattern is fine. They're happy. And this is just talking about the family planning study. Of course, if you have a high BMI, so if your BMI is getting to be over 35, you may not want to use the combined pill on top. If you're wanting to sort out the bleeding pattern, although there's not a lot of randomized evidence, I would give some progesterone for a few weeks and see if that works. Good question.
With the high BMI and the effectiveness of gel, do you have to remove it or change it earlier?
No, I'm just going to come to that. I think the data that we have from the Faculty of Family Planning and Reproductive Health Care is that they are absolutely happy for the J-Dells to be left in for the 5 years, even for one with high BMI. I know that Pharmac did put out something at family planning, we're leaving them in for the duration. On that 5th year, the failure rate goes up to around about 1%, which is a lot better than anything else you're going to be able to offer them. And yeah, happy to have questions as we go through. So I've talked about putting a pill on top to help the bleeding pattern with implants. It works really well. Do that as soon as the woman comes. There is a real window of opportunity from the research where if you keep saying, oh, look, go away, it'll probably get better in a few weeks, women get fed up and then they come and they just have it removed. So as soon as you can actually see them, they're having bleeding, of course you're checking that there's an up-to-date smear, of course you're checking whether they need a chlamydia check, that there's not any other reason for bleeding, but if it seems to be due to the implant, which it probably is, give the pill on top. And you can do that, as I say, for as long as the woman wants to use it for continuous hormones. Question up here.
So if they are bleeding, but they don't want to be using the COC long term, do you give it to them for, say, 3 months to let them have a withdrawal?
Yeah, absolutely. So 3 months back to back, 21 pills, 21 pills, 21 pills, no placebo pills. So it's 63 hormone pills. That usually will help the bleeding, and then you hope when you stop that it may sort out the bleeding pattern. Yep. So again, as with Depo-Provera, with the implants, there isn't any causal association with weight change, mood change, or libido. The main side effect profile is the bleeding that we just talked about. Same thing with headaches and acne. The data is all over the place. It may not change. It may actually improve. Sometimes it worsens. We don't really have a good overall thing to say about acne. It's worth trying for women who want really good contraception. It may not make their acne worse. Here's what we just talked about. This is again from the Faculty of Sexual and Reproductive Health Care. Use it up until the 5 years, even if your BMI is over 30. So this is the website, and you should have, say this as your favorites. It's really useful on your computer. Here's a URL to get into this website. And the reason the website's really good is here's all the evidence-based guidance on the pill and implants and all the methods of contraception. So you can quickly look at those. But the easiest thing, the thing that's really, really great about this, is that you can actually search. So there's a search engine up here. So quite a lot of you will email me at the university and say, Helen, I had this woman with me. She's got benign intracranial hypertension. I'm not quite sure what contraception she can use. What do I do? Well, I happen to know about benign intracranial hypertension, but there's lots of things you ask me about I don't know about. And what I do when I get your email is I go immediately into this, I put it into the search engine, I spit out the answer, and I email it back to you. And I'm really happy to do that, but you might as well have a wee go yourself. It takes 2 ticks. So we've been talking about body weight. So you can see that once you're over 30 to 34, the combined pill is 2. So maybe that woman who was bleeding in the implants, if that's her BMI, yes, you could put the combined pill on top. But if it's over 35, maybe you wouldn't put the combined pill on top to help her bleeding pattern. Maybe you just give her some extra progestogen. So these are a few things that have changed. This website will show you these. It's the UK medical eligibility criteria. There's summary sheets. Again, you could actually have those as favourites or print them off. A lot of GPs just have them sitting there on their desk so they can look things up. And as we know that migraine with aura, you shouldn't use a combined pill, but migraine without aura, actually 2 to start it, that's fine. But if you're on the pill and you start to get migraine without aura at any age, it becomes a 3 for continuation. Maybe that woman should come off the combined pill and use something else. What is a migraine with aura? No flashings. No, that's not aura. So it's homonymous hemianopia. It's a scotoma, either clear or black, defect in the field of vision bilaterally. Flashing lights are okay, fortification spectrum's okay, headache's okay, of course, unilateral headache.
Or neurological in the body.
Or neurological, so tingling up and down one side of the body or loss of power on one side of the body. It's the visual symptoms that people get wrong. So flashing lights are not an aura, fortification spectrum's not an aura, it's the homonymous hemianopia, the scotoma. That is the thing that you're really, really looking for. That's the migraine with aura. There's a really, really fantastic paper by Anna Glacier, who's a Scot from Edinburgh. Obviously, she's a Scot from Edinburgh. I don't know why I made that comment. And if you like, I can send it to somebody. It's just a gorgeous description of how you ask about getting the history for migraine with aura. And it's really important to get it because otherwise you're actually telling some women you shouldn't be using a combined pill because you have migraine with aura when they don't have migraine with aura. So maybe I could send it to somebody and you could send it out if you'd like.
Wasn't they get the sclerotoma, the sclerotoma on one side? That's quite common. They get that, and then the headaches on the other side.
So the fortification spectrum is fairly common.
But
yeah.
on one side only. They get the fortification on one side. Is that?
I think that's a difficult thing to elicit, actually, because you may well think it's particularly more in one eye and the other, but sometimes it is just on one side. Mm-hmm. Yep. But it's the scotoma that's making the diagnosis, not the fortification.
Oh.
Yeah. And people are still arguing about this. You can take the pill if you've had gestational trophoblastic disease, even if you have still elevated beta HCG levels, you can start to use the combined pill if you want to. I'm just going to go through a few more of these and then we'll move on because these are all here for you to look at. There still is some messages out there that if you've had previous PID, you've had previous ectopic, you cannot use an IUD. Of course you can. It's all a one. Obviously, if you have an IUD and you're going to do an insertion and you have chlamydia there before you're putting it in, you would treat it and then you would put it in. But if you have an IUD in and the woman has chlamydia, don't take the IUD out, just treat the chlamydia. But previous PID, previous ectopic, perfectly okay to use IUDs. And of course, this is quite a few years ago, but we now know, or we're now accepting that there's not really any major interaction between the combined pill and antibiotics unless they're enzyme inducers. So you don't have to talk about 7-day rules or any of that sort of stuff. So we're going back to this faculty, and I just want to show you an example. Here is this woman with intracranial hypertension, benign intracranial hypertension. You can actually put it in the search engine, and they will give you the answer suggesting not using hormones, not using estrogen, not using progestogen, obviously that woman could use an IUD, but perhaps liaising with her neurologist if she really, really wanted to use hormones. I'm going to scoot on because there are 5 minutes, so I think you know the rules of Miss Pills. Please consider offering all women who are on the pill continuous hormones. Most of our young women are now using continuous hormones. They're not taking the break. Who wants to have a period? They're getting much better contraception. You can happily do that for the next 20 years if you want to. So lots of women are using the pill without taking the break. I think we don't need to labour this point. We know that IUDs don't cause infection. It's usually the sexually transmitted infections. So adolescents can happily use IUDs as long as they're given the same advice as those of us who are older. If you're changing partners, use condoms. We're trying to facilitate things for women, so it's a one-visit IUD insert. We're not routinely doing swabs for women in a stable relationship. Even if we have BV these days, we're not treating that before we put an IUD in. As long as the woman hasn't had unprotected sex since her last period, you can go ahead, see her, put the IUD in at that visit. So you don't need to do pre-swabs and bring her back. Let's facilitate use of contraception. If you have a woman who has a tight os and you're not happy to use a paracervical block, they're extremely easy to put in. But let's have a look at some of the IUDs which you might want to use. So you may remember seeing this. So as well as now having the copper T380A, which really has a little bit of a complicated introducer, we now can get from a Pharmac decision, the choice load 375. I suggest to you, if you're feeling a bit uncomfortable, if you're an IUD inserter and you don't like the TT380A, and lots of people don't like it because it's a bit clumsy, it just looks exactly like the old multi-load looks like, but the inserter is a little bit narrower. Really, really nice to put in for women. So if you've got os that's tight at all, this will slip in much better than a copper TT380A, and you can get it on a practitioner's supply order. So that's the TT380, and that's what the choice load looks like, just like our multi-load. We now have JDES, of course. It's a smaller Mirena, smaller insertion tube. Its indications really are for contraception and not for heavy menstrual bleeding and endometrial protection as the Mirena. And it's about $250 as opposed to Mirena, which is $350, unless you can get your Mirena subsidized. And I just want to talk about this briefly, then I'll finish. This was a BPAC document. So there was quite a lot of research done about, here are the manufacturer's recommendation duration of use for various IUDs. And this research showed that perhaps we can extend this. Faculty of Family Planning and Reproductive Health Care has suggested that perhaps a lot of this research was in women in their 40s. But let me say to you, I guess the message is, of course, if you're a woman over 40 and you put an IUD in, it can stay into menopause. If it's a Mirena and she's over 45, it can stay until menopause. But if you have a woman of any age and she comes to you and she has, say, the choice load in, like the multi-load, and the manufacturer's recommendation is 5 years, and she's, 26 or 27, if you're not an IUD inserter, it doesn't have to come out. It could stay in for another year until she finds somebody who can take it out and put a new one in at the same time. There's not a rush to be taking these things out unless you're feeling that, yes, I do IUDs, I'm going to take one out and put one in for her today. I guess that's the message with the extended length of use. And I think I'm just going to scoot on a little bit. The message here is that if you have women with a BMI over 25, it looks as if the emergency pill Postinor doesn't work very well. Either these women should be offered a double dose, because it looks as if they've done some pharmacological kinetics that looks as if the dose is going to be enough to prevent ovulation in obese women. But the best thing for these women, if you can do it, is to organize a post-coital IUD, either at family planning or yourself, if that's what you do. And that's really, we know we can put in a postcoital IUD if it's within 5 days of the earliest expected date of ovulation. Fertilization occurs, 7-day journey to get in. If the IUD is in by 5 days, that will stop implantation. All right, I think it's morning tea time unless we want 30 seconds for questions.